Well, good afternoon, all. We're going to continue on with our spinal cord injury lecture series. Today, we're going to go through the international standards for the neurological classification of spinal cord injury. These have been updated in 2019. And so hopefully I can get control moving forward. We'll talk through the revised version of the standards, talk about optimal testing, both for the sensory as well as the motor function. We will run through how to determine the neurological level of injury, the completeness of the spinal cord injury, the Asia impairment scale, and that'll include both the grade as well as zone of partial preservation, and then talk about pertinent revisions and expectations for in-ski reporting. If you have questions or comments during this, feel free to speak up and or put in a chat. I'll try to keep track of the chat, but sometimes that gets away from me as we're going through. So we'll start off with the discussion on the sensory testing. So basically, one of the key things to remember is that we are making assessments at each dermatome in reference to the face. And so we'll do that for both light touch as well as pinprick sensation. The reference point is the person's cheek. If they have no sensation in their face or cheeks, then we have to score all dermatomes below that as non-testable. We'll talk through how to do the light touching or the sharp-dull discrimination. Remember that we're going to use dermatomes from C2 all the way down to the sacral elements. When a sensory point is unavailable, any spot within that dermatome can still be used, but you have to note that you've used someplace other than the usual spot in the box on the worksheet. So as we go through our sensory testing, remember that we'll score it basically 0, 1, 2, or not testable. 0 means that the person has sensory absent at that dermatome. A 1 is altered, and that can either be decreased or impaired, or it can be hypersensitive. And then 2 is a normal relative to their cheek as we're going through there. Non-testable is listed if you have a non-spinal cord injury condition present, if the person is covered by a cast, for example, or if you've had other things associated with it, for example, a plexopathy or some other sort of thing that would make testing inappropriate. Peripheral neuropathy, etc. Our tools are going to include the tapered wisp of cotton. Typically, we'll be using a Q-tip for that, and so you just pull this out to the side. For light touch, we're going to stroke the skin just 1 centimeter at the key point of the dermatome, and then ask if it's the same as their face. Remember that 0 is what you put down if they have no sensation. 1 for impaired sensation, that's either hypersensitive or hyposensitive. And then normal sensation, at least 8 out of 10 times they reported appropriately. So they have to be 80% correct on each dermatome. And then you are going to list if it's not testable. If a non-spinal cord injury condition is present, you can still report out what they perceive, but you want to make sure that that's characterized by an asterisk. So if they say that it's impaired, but they have a brachial plexus that could explain that, then you're going to put what you find, that is a 1, but with an asterisk, indicating that it might not be because of the spinal cord injury. The sharp, dull discrimination is by using a safety pin. You touch them 1 time and ask them if it is sharp or dull. And if they say it's sharp, then you ask if it's the same as their face. 0 is no distinction between sharp and dull, so they can't really discriminate. So if they can feel you touch, but they can't discriminate sharp from dull, then it's still a 0. 1 is impaired, again, hypo or hypersensitive, and 2 is normal sensation, at least 80% of the time. NT is written down if it's non-testable, and then again, if you have a non-spinal cord injury condition present, you're going to put that as an asterisk to explain that there may be another reason other than a spinal cord injury why that sensory level is impaired. So this is the typical INSCI worksheet that you're all hopefully familiar with, but if not, let's spend some time going over it. The light touch will be listed for right sides as well as the left sides on both sides of the body. And we've got 28 dermatomes that we're going to assess for light touch. We're also going to do pinprick on each side, the right side as well as the left side. And again, 28, so that your total number for the right side light touch is going to be 56, pinprick is going to be 56. For the left side could be 56 for light touch and 56 for pinprick. You're going to subtotal those and then add them together, and we'll talk through that a little bit more. And again, you always have this to go back to if you need to. Just as a reminder, 0 is absent, 1 is altered, and 2 is normal. NT is non-testable. 0, 1, or non-testable with an asterisk indicates that a non-spinal cord injury condition is present. So we're going to spend some extra time as we talk through the deep anal pressure. That would be sensation in the sacral elements, and or light touch or pinprick in the sacral elements are going to be important for us as well. So I want to run through the dermatomes first, and they're listed as we go through. You can see these in the INSCI manual as well. C2 is 1 centimeter lateral to the occipital protuberance, that is 2 centimeters behind the ear. C3 is in the supraclavicular fossa at the midclavicular line, and C4 is at the AC joint, basically as we're going through these. I'm going to jump down to the hand for a minute. We'll come back up to the elbow. C6 is the dorsal surface of the thumb. C7 is the dorsal surface of the middle finger, and C8 dermatome is the dorsal surface of the proximal phalanx of the little finger. As we look at the elbow, the lateral elbow, basically, just lateral to the antecubital fossa is going to be considered our C5 dermatome. The medial, if you want to consider the medial epicondyle, basically is T1, and then T2 is in the axilla. As we work our way down, T3, basically we're going to be looking at the midclavicular line on the right side of the body and on the left side of the body. T3 is basically at the 3rd intercostal space. T4 is at the nipple line, basically the 4th intercostal space. T5 is the 5th intercostal space, halfway between T4 and T6, which is at the xiphoid process. I'm going to go all the way down to T10. T10 is at the umbilicus. T8 is halfway between T6, the xiphoid process, and the umbilicus. T7 is halfway between T6 and T8. And T9 is halfway between T8 and T10 as we work our way down through there. T12, again, midclavicular line at the inguinal ligament. And T11 is halfway between the T10 and the T12 dermatomes. The myotomes for the thorax are basically attributed to the dermatomes. There are very few folks who can independently activate a T7 myotome or a T9 myotome, and short of a few belly dancers, we feel that it's more appropriate to use the dermatomes to assign the myotomes in these scenarios. The L1 dermatome is midway between T12 and L2. L2 is basically the anterior medial thigh, midway between the middle portion of the inguinal ligament and the medial femoral condyle, and L3 is at the medial femoral condyle that is right around the VMO, vastus medialis obliquus complex. So then we go down to the medial malleoli. This is where we're going to find our L4 dermatome. The L5 dermatome is the dorsal portion of the foot at the 3rd metatarsophalangeal joint. S1 basically is at the lateral heel, so the lateral aspect of the calcaneus. and S2 is the midpoint of the popliteal fossa. And we look at S3, which is considered over the ischial tuberosities, or the infragluteal fold, and then S4 and 5 as you move in towards the perianal area, so less than 1 centimeter lateral to the mucocutaneous junction. So these are our key dermatomes from C2 all the way down to S4 and S5. Common pitfalls associated with these would be misinterpreting the patient's response. Sometimes the age of the patient, for example, the pediatrics has a different set of standards. They use the we-step instead of the in-step process. If I provide a poor explanation or I don't give them appropriate directions, including discouraged guessing, then we might have an inappropriate exam. If the person is cognitively impaired and simply can't understand what it is that we're trying to do, and if they have delayed sensory responses, sometimes that can be confusing. So I want to talk us through the myotomes now, and we'll come through those, and then we'll talk about going through the steps in the INSCI classification. But basically, as we look at the motor exam, we keep in mind that we are essentially looking at, on a 0 to 5 scale, this is ordinal data. So essentially, who's this guy? Had something to do with gravity. So just keep in mind that the first couple of numbers that we might put down have to do with what the person can do with gravity eliminated. So if there's no visible or palpable contraction, you give them a 0. If they have a trace voluntary contraction, but they can't take it through a full range of motion with gravity eliminated, you're going to award them a score of 1. If they can go through the full range of motion with gravity eliminated, then we're going to score them a 2. And then we go into the gravity side of things. If they can move the limb through its full range of motion against gravity, then we give them a score of 3. If they can move it through the full range of motion with full resistance, that is age and gender matched, we give them a score of 5. And anything less than full resistance, but greater than just anti-gravity, we're going to give them a score of 4. NT, again, this is not testable. You're unable to test. For example, the person is missing a limb, the person is in a cast that doesn't allow them to move through full range of motion. If they have a contracture, those types of things would be considered. Used to be, we would tell you what we thought would be their score if they didn't have function there, but we thought it was for some other reason. The new guidelines actually tell us to ascribe the score that we see and then put an asterisk if we think that it's related to some non-spinal cord injury condition. So for example, a plexopathy may be contributing to it. So again, on the INSCI evaluation forms, the motor testing, you've got 5 myotomes in the right upper extremity, 5 myotomes in the right lower extremity. You've got 5 myotomes on the left upper extremity and 5 on the left lower extremity. Also keep in mind that we're going to be testing voluntary anal contraction. That's a separate myotome, if you will, but it's going to be very important as we try to prognosticate how a person is going to do from there. So during this next session, I'm going to run through these fairly quickly because I want to be able to have some time to go through we have several cases. So as we look at elbow flexors, and we're looking at grades 0 and 1, again, this is with gravity eliminated. We're going to have the shoulder in an internally rotated and adducted position. The elbow is going to be in 30 degrees of flexion, and we're going to have a neutral hand position with the wrist on the abdomen. And basically with the examiner supporting the forearm, looking very closely to see if the person is able to activate their elbow flexors. So we ask them to bend their elbow, try to bring their hands to their nose. And so you're going to indicate whether or not this, if it can't go through the full range of motion, then it could be a 1. If there's absolutely no flicker of movement, then you're going to rate this as a 0. For a 2, again, we're going to have them in this position. We're going to ask them to bend their elbow, bring the hand to their nose, and they need to take it through the full range of motion in order for me to give them a grade of 2. For a grade of 3, now I'm going to change the position with the elbow extended, their forearms supinated, basically ask them to bend their elbow and bring the hand to the nose. So they're attempting to flex the elbow through its full range of motion. If they can get that through there, we're going to say that's at least a grade 3. If they're not able to provide significant resistance, we're going to keep that at a 3. But otherwise, we then bring their elbow to a 90-degree flexed position with their forearms supinated, and we're going to ask them to hold their arm there, don't let me move it. And I'm going to rate this against age and gender matched what I would consider normal strength. If it's normal, then I rate it a 5. If it's less than normal, then I'm going to give them a grade of 4. Wrist extension. Again, we're going to go through this process of eliminating gravity. And so with the elbow extended, the forearm neutral, the wrist fully flexed initially, we're going to ask them to bend their wrist backwards. Again, this is gravity eliminated. If there's no palpable movement, we score them a 0. If they can get it partway through the range of motion, but not fully, we score them a 1. And if they can get it through the full range of motion with gravity eliminated, we score them a 2. As we're looking for a grade 3, now we're going to have the elbow extended with the forearm pronated, the wrist flexed, and ask them to bend your wrist upwards, lifting your fingers towards the ceiling. So again, what we're looking for is anti-gravity strength through the full range of motion. If they can do that, then they're a grade 3 or more. And then we're going to ask them to extend the wrist fully, and we're going to try to push it down. And I'm going to score that as either a 5, which is age and gender matched normal strength, or something less than a 5 as we go through this. C7, now we're looking at elbow extensors. That's our key muscle group. So with the shoulder internally rotated and adducted, elbow flexed 30 degrees, the forearm over the abdomen, supporting the elbow and wrist, we ask the individual to straighten their arm, and they try to move it through full range of motion for elbow extension. Recognize that you need to hold the elbow because they can use external rotators, abductors, and elbow supination, all of which are C5 or C6 innervated muscles, to mimic elbow extension. And so keep that in mind. They can functionally substitute, and we want to make sure that we're actually grading the elbow extensors. So I like to actually hold the elbow in place so that they're not able to use those additional features. Grade 0 is, again, no activation, no palpable muscle movement. A 1 is you can see a flicker of movement, but the person can't get their elbow through the full range of motion through extension. Or a 2, they can make it through the full range of motion as they try to straighten their arm. A grade 3, now you're going to flex the elbow fully, have the hand resting by their ear while they're lying down, and you're going to ask them to straighten their arm. If they can do that against gravity through the full range of motion, you're going to grade them a 3. Then you're going to determine if they have a grade 4 or grade 5 strength. So with the elbow flexed at 45 degrees, you're going to support their upper arm and ask them to hold that position against you as you try to pull the extended elbow into a flexed position. As we look at C8, again, grade 0, 1, and 2, this is with gravity eliminated. Now we're going to hold with the elbow extended, the wrist in a neutral position, stabilizing the MCP and PIP joints. Ask the individuals to bend the tip of their middle finger. This is the key muscle group that we're looking at. If there's a flicker of muscle, then we could grade them a 1. If they can get it through the full range of motion, it's at least a grade 2. To give them a grade 3, we're going to turn the hand in a supinated position. And again, stabilizing MCP and PIP joints. Ask them to bend the tip of the middle finger. If they can get it against gravity, then we'll give them a 3. If they do get a 3, then we're going to ask them to flex their digits fully, and we're going to try to extend the fingers. So we say, bend the tip of your middle finger in this position. Don't let me move it. And again, we're looking at age and gender matched normal strength or something less than normal as we go through there. The T1 finger adductors. So again, what we're looking at here are the hand intrinsic muscles, particularly abductor digiti minimi. We're going to look for less than anti-gravity strength by having the wrist in a neutral position, the MCP stabilized, and asking the persons to move the little finger away from your ring finger or spread your fingers apart. If they can get through that full range of motion, they're listed as a 2, could be more. If they can't get through the full range of motion, you're going to grade them a 1, and if there's no flicker of muscle movement, then you grade them a 0. For a grade 3, you actually turn their hand so that the little finger is pointed up towards the ceiling, and then you ask them to move the little finger away from the ring finger so that we're seeing if they can move against gravity. If they can, then we move them forward and ask them to completely abduct that little finger. And we say, hold your little finger away from your ring finger, don't let me push it in. And again, we're going to grade this as a 5. It's age and gender matched strength, normal strength. If it's less than that, then we're going to grade it a 4. Then we all go all the way down to the lower extremities. Again, the hip flexors, grades 0 and 1. So basically, we put them in a gravity eliminated position where we turn the knee out to the side, and we see with gravity eliminated if they can move their knee up through the full range of motion. So we ask them to move their knee out to the side. If they aren't able to, and you can't see a flicker of movement, then we rate that as 0. If they can move it but not through the full range of motion, we give them a 1. We're going to similarly see, while we support the leg and ankle, if they can move their knee out to the side through the full range of motion, then we score them a 2. And then I skipped the 3, but basically if they can lift their leg up against just gravity with the leg extended, then we give them a 3. Then to check for a 4 or 5, we're going to essentially ask them to hold the knee up in a flexed position. Don't let me push it down. And again, I'm going to be rating this as a 5, which is age and gender matched, or a 4 if it's less than normal strength. So the knee extenders, again, eliminate gravity by putting the leg out to the side, externally rotated. And you're going to support the distal thigh and ankle. Ask them to straighten the knee. You want to look for a palpable or visible movement of the quadriceps. If it's present, but they can't get their leg through the full range of motion with gravity eliminated, you give them a 1. If there's no palpable movement or no visible movement, you're going to grade that as a 0. A grade 2 is basically where, with gravity eliminated, they can move their lower leg through its full range of motion when you ask them to straighten their knee. For a grade 3, now we're looking at anti-gravity strength. You can actually reach across and support their leg by grabbing hold of the opposite leg and then asking them to lift their heel up off the bed, straightening their knee. So you're looking for their ability to take it through its full range of motion. And then for a grade 4 and 5, you're going to flex the knee at 15 degrees. And you're going to press down and ask them to hold that position. Don't let me bend your knee. So again, looking at a 5 as age and gender matched normal strength. Less than that is going to be a grade 4. Ankle dorsiflexors, again, you're going to eliminate gravity by externally rotating the leg out to the side, supporting the leg under the knee and ankle, and ask them to lift the toes upward toward the head allowing the ankle to bend. I actually ask them to bend the ankle because I don't want to just look at their EHL function there. And so you're looking for a visible contraction of the anterior dorsiflexors and to see if they can move the ankle through its full range of motion. If they can't move it through its full range of motion with that gravity eliminated, you score them a 1, or if there's no visible or palpable contraction, you score them a 0. For a 2, again, you're going to see if they can, with gravity eliminated, lift the ankle and see if they can bend it to a fully dorsiflexed position with gravity eliminated. For a 3, you're going to hold their leg and while supporting the leg under the knee and ankle, ask them to bend the ankle to the foot, to pull the foot up against gravity. If they can get it through its full range of motion, you score them a 3. And then for a grade 4 or 5, you ask them to fully dorsiflex and you try to push down and determine if they have age and gender matched normal strength or something less than that. EHL, again, this is the L5 muscle group. With gravity eliminated, that is lying the ankle down on its lateral malleolus, basically asking them to lift the big toe up towards the knee. And you're looking for a either visible or palpable contraction. If they can give you that contraction, you're going to score it a 1 if they can't get it through its full range of motion. If they can, with gravity eliminated, get it through its full range of motion, then you're going to score them as a 2. For a 3, again, you're going to have them move it against gravity, lift your big toe up towards your knee. For a 4, you're going to have them up in a, essentially the extended position for the toe, keep it lifted up there, and don't let me push it down. And you're going to score them as a 5 if it's age and gender normal strength. If it's less than that, you're going to score them a 4. For the plantar flexors, again, eliminate gravity. Look for the calf muscles to plantar flex. If you don't see any movement there, you're going to score them a 0 with gravity eliminated. If you see some movement at the ankle, but they can't get it through its full range of motion with gravity eliminated, then you're scoring them a 1. Again, if they can move it through its full range of motion with gravity eliminated, you'll score them a 2. And then a 3, you're going to actually have them basically with the knee fully flexed, the ankle in a fully flexed dorsiflexion position. You're going to ask them to push the foot into ankle dorsiflexion position with the heel on the table. And basically, you're looking to see if they can lift their heel off the table. Once they've done that, they've scored a 3. Then you're trying to determine if it's normal strength or not. So you have them push their foot down and then ask them not to let me push it up. I'm going to be trying to force it into a dorsiflexed position. I score them a 5 if it's age and gender matched normal. Less than a 5, that is a 4. If it's not at least age and gender matched normal. So these are the common testing pitfalls that we come across. Again, PEDS, there's a different set of standards, and we can talk through that at a different time. We need to make sure that we discourage them from guessing. Cognitive impairment sometimes will limit their ability to fully participate with our examination. We may be lacking in experience or positioning them inappropriate in order to fully test that motor group. Improper palpation, not checking passive range of motion before we go through this. Recognize that some movements can be because of reflex withdrawal or spasticity. Again, recognize that folks can use muscle substitutions, which we encourage, by the way, during rehabilitation, but not while we're testing them. And then making sure that we don't use pluses or minuses when we're doing the INSCI examination. I don't mind that when you're using it for manual muscle testing for any other diagnosis, but they're very, very strict. We are very, very strict about how we grade motor strength. and it's without pluses or minuses as we go through there. Now, the other time that you might consider using other muscles of similar myotomes is when you're trying to discriminate between an Asia Impairment Scale B or Asian Impairment Scale C. And so I might, if somebody, for example, has some hip adduction, I might report that, and I'll put that over on the side of the box, because that tells me that they've got some motor movement below the level of the injury, and I want to give them credit for that. That's also going to help me with regard to prognosis. And that's one of the major reasons why we would include some of these optional muscle groups to be tested. So the other thing that we need to consider is down in the sacral elements. And again, this has a lot to do with prognosis for particularly motor recovery, not just sensory recovery. But we're going to be reporting out on whether the person can voluntarily squeeze the anus around the finger while it's there, and whether or not they can discern deep anal pressure. Now, I don't say this lightly. It's very important as you're doing this to discriminate from reflex activity as opposed to true voluntary squeeze, and to recognize that deep anal pressure, sometimes they sense pressure, but what they are actually experiencing is some autonomic dysreflexia in response to a noxious stimuli below the level of the injury. And so you have to get them to make sure that they're truly experiencing sacral pressure and not an increase in blood pressure or some other way that they are experiencing autonomic dysreflexia in response to this noxious stimuli. So common anorectal testing pitfalls. Again, PEDS, there's a different way that we do this testing. If we make sure that we discourage guessing, and then we also have to discriminate a very tense patient, and just realize that sometimes that could throw us off in terms of what we report. Making sure that we're not reporting reflex contractions. How do you do that? Once your finger is inserted, you make sure that the person is stable and normal, and then you ask them to squeeze around your finger, and make sure that they're not using other muscles to functionally substitute, for example, gluteal contractions, that they're not able to activate their abdominal muscles, and that seems to precipitate a reflex contraction. So these are pretty important features as we go through this. Now I want to go through the different steps in classification for the INSCI determination. So again, our sensory scoring, we have a maximal score of 56 on the right side, 56 on the left side for upper and lower light touch as well as pinprick. As we go through, we have to make sure that we report if a dermatome is not tested, or if you're using something other than what we are qualifying. So as we go through this, again, keep in mind light touch on the right side, light touch on the left side at each of 28 dermatomes would give you a total score of 56 on the left. If everything was intact, 56 on the right, and you would add those two things up for a total score of 112. You're going to similarly add up scores at each dermatome for your pinprick. And keep in mind that when you're doing your pinprick, it's not enough to just say, I feel that. They have to be able to discriminate at least 8 out of 10 times a sharp from a dull touch as they go through that. So again, for a possible total of 56 on the right side, 56 on the left side, and a total score of 112 for pinprick sensation. Then you're going to determine the motor levels for the right and the left side, keeping in mind that you can have a total of 25 on the upper, a total of 25 on the lower for a score of 50 for your total motor score on the right, 25, 25, 50 for your total motor score on the left. So if you add those all up, you could have a total motor score of 100 if the person is completely intact. Then you put all these together, and we keep these scores in mind because, again, from a prognosis standpoint, changes at 3, 6, or 12 months will give us some indication of whether or not the person may naturally develop some motor recovery, is particularly what we're looking for as we go through this. Then we're going to determine the neurological level of injury, and this refers to the most caudal segment at which you have intact sensory function and at least anti-gravity strength, that is a motor score of 3, with the just rostral component being of normal, or 5 out of 5 strength. So basically you're going to use these two components to help determine what your neurological level of injury is, using your most caudal normal, that is grade 2 dermatomes for both light touch and pinprick. And you're going to do the same thing for the motor level, recognizing that you have to have at least a score of 3, and the just rostral muscles, the ones just proximal to that, have to be of normal motor strength, that is a 5, or the dermatome has to be completely normal with light touch and pinprick. If you have a myotome sitting below what you used as a myotomal attribution because of the dermatome. That'll make more sense as we look through a few of our cases. So the neurological level of injury is the most rostral of all the normal sensory and motor levels as we're going through this. Then we're going to determine whether the injury is complete or incomplete. So again, what we're looking for here is particularly at the sacral elements. Keep in mind that as we look at particularly the S4, so this line basically is the line that you want to look at to determine if you have a complete or an incomplete injury. To have a complete injury, you have to have an absence of voluntary anal contraction, an absence of all sensory function, light touch, pinprick, as well as deep anal pressure. So if this is N, no. If that is, they have no anal contraction. If they have no deep anal pressure, and the light touch and pinprick are both zeros, you end up looking at this as if it's a noon. And so anything less than that, that is, if you have a yes, if you have a yes, if you have a 1 in any of these 4 boxes, then it would be an incomplete injury. So incomplete injury indicates that you've got at least partial preservation of sensory and or motor function at your sacral elements, that is S4 and S5. So sensory incomplete means that your sensory levels, either this box, this box, this box, this box, or this box, are something other than 0 or no. Motor incomplete means that you've got motor function, basically with voluntary anal contraction. So as we go through this to determine complete or incomplete, then we're going to make a determination about Asia Impairment Scale A, which would be complete, or if it's not complete, is it an Asia Impairment Scale B, C, D, or E? And we'll come down through those as we go through there. So basically B is you've got sensory incomplete, but no motor function preserved more than 3 levels below the motor level on either side of the body. A C is that you have motor incomplete, that is, you have sensory and or motor function preserved in the sacral elements, and you have at least 1 muscle group functioning at less than anti-gravity strength, and all you need is just 1 motor group to become an Asia Impairment Scale C. But the majority of muscle groups below the level of the injury are considered less than anti-gravity. For an Asia Impairment Scale D, the majority of muscle groups below the level of the injury need to be anti-gravity or more. And then if you have ND, this is when it's not determined, so that you don't know, and that's because of incomplete scoring for one or more reasons as we go through this. So again, sacral sparing or not, if this is noon, then you have a complete injury, and you can say Asia Impairment Scale A. If you have anything other than N, O-O-O-O-O-N, then this is an incomplete injury, and you're going to be at an Asia Impairment Scale B, C, D, or E. So again, Asia Impairment Scale B is where you have sacral but no motor function spared below the level of the injury and including the sacral elements. C is you have motor sparing but less than anti-gravity motor strength in the majority of muscle groups below the level of the injury. Asia Impairment Scale D is sacral sparing and greater than or equal to anti-gravity strength in the majority of muscle groups below the level of the injury. And Asia Impairment Scale E means that you have normal motor function and normal sensory function in all of the dermatomes and myotomes below the level of the injury. So why would you even score it as an E? And that has to do with spasticity. Recognize that folks, even though they may have normal motor and sensory function, who had a spinal cord injury are going to be at increased risk for hyperreflexia, spasticity, not just at the musculoskeletal level, but also their bladder and sphincters, their guts and sphincters are going to be at high risk, and this can also cause autonomic dysreflexia. For the bladder components, it could cause vesicoureteral reflux, acute renal failure, and death. So just because they have Asia Impairment Scale E, or I should say maybe because they have Asia Impairment Scale E, keep in mind that they can still have significant medical complications because of spasticity. So these are the steps. The other thing that we want to do is talk about the zone of partial preservation. And again, this is only in injuries with absent motor or sensory function in the lowest sacral elements. So we'll come to these. Used to be that we only included these for what we called complete injuries. Now if you have sensory or motor incomplete injuries at the sacral elements, then we're also going to be reporting out to zone of partial preservation. So keep in mind that if you have absent deep anal pressure, then you're going to be reporting this out as part of the zone of partial preservation. If deep anal pressure is present, then the zone of partial preservation is going to be listed as non-applicable. So we'll come through as we get some cases for these. So again, when do you tag your scores? This is when you take into account, this basically we used to just use clinical judgment. Now we're actually reporting out the scores, but we're indicating that those scores are probably abnormal because of some other component. So again, a plexopathy, a peripheral mononeuropathy, something like that. So we will be scoring those. So now, I don't know who all is on, but I'm gonna take a chance that our PGY2s are all present. And so that being the case, I'm gonna assign different cases. So Dr. Madhu, are you on? If you are, please unmute yourself. And if anybody knows that he's not here, just let me know that, and we'll move on to one of the other PGY2s. I'm not hearing anybody. Is Dr. Madhu there? Let me move on to another.
Dr. Gator?
Yes.
He's at the VA. I'm not sure if he can come to these lectures.
So let's move on to Dr. Volmrich. Volmrich or Volmrich? Is she there?
She's also at the VA.
What? Okay. Dr. Amarianafar. I didn't pronounce that correctly. Amarianfar.
I'm here.
Yes.
Yeah, it's Amarianfar.
Amarianfar. Yes, I knew as I was putting that out there, it didn't work. So let's start with this case. You're going to help me work my way through case 1, okay? These are our findings. Somebody had already gone through and
Remember from last year.
they had recorded these for us. And so I want you to start off with, as we would do through our usual ASIA determinations or INSCI determinations, what would you call the right side sensory level for this individual? And why? So you look at sensory and you find the last normal.
Yeah, I would say C6.
C6 on the right, and how about on the left?
I would say C6 as well.
Okay, very good. And what would you call the motor level? So now you look at the motor levels on the right.
Mm-hmm.
And you want
C6 on the right and C6 on the left.
C6 on the right and on the left. Okay.
Yes.
And what would you call the neurological level of injury?
Give me a second. I would say it is, I want to say C7.
Why would you say C7 when C6 is your last normal?
Oh, I'm sorry, C6, excuse me.
Yeah, so you want to, your neurological level is assigned as the last normal motor and sensory function. And normal motor function is at least a 3 with the more rostral myotome being a 5. Okay, so you decided on what?
C6.
C6.
That's my final answer.
That's your final answer. And would you call this a complete or incomplete injury? So you're going to look along this line, and if it's new.
Oh, yes. I want to say it's the noon sign. I believe the noon sign is, it's a complete injury, correct?
That's correct. And so what ASIA impairment scale would you assign?
Oh, I'm going to go with, is it D?
So a complete injury, noon sign is also associated with ASIA impairment scale A. A is the complete injury.
Shoot. Okay.
The incomplete injuries are B, C, D, and E. So your final answer here is going to be
A.
A. And zone of partial preservation, do you have some partial preservation for sensory?
It looks like we do.
For sensory?
Oh, no, I'm sorry. Not for sensory. For motor, we do, not for sensory.
Okay, so you're going to list, what do you have as your sensory level?
C6.
Where you have something other than 0.
I don't see anything other than 0 except for C6.
Yeah, so you could go ahead and list C6, and then your motor function is spared as what level? Do you have below the level of C6, which is your neurological level of injury, did you have any motor function spared? Anything other than 0s, all the way down on either side? And if so, at what level?
Edwin, you're muted.
Oh, sorry. C7 at both sides. Thank you, Nate.
All righty. So C7. So this is what we find as he had completed this. It's hard to be the first one, isn't it? So the first one out of the chute, but you did a good job. So this is a C6 complete spinal cord injury. You would say the person has C6 ASIA impairment scale A tetraplegia.
Yep.
All righty. Good job. Let's move forward. Case 2 is Dr. Goudet. Goudet?
Hi, how you doing?
I'm well. How are you doing? You're going to help me assign an ASIA impairment scale for this this individual.
Sounds good.
So start off with the
course,
sensory level.
the sensory level would be C3 on the left and C4. Oh, excuse me, C3 on the right, C4 on the left.
Okay. And your motor level.
We don't have one.
You do. You have a motor level.
C5.
Would you call it C5 on the right?
Yeah, C5 on the right, and C5
Even though
also.
C4 is not normal?
I guess not.
Okay. So if C4 isn't normal, then you have to go to,
Oh, C3. Yeah.
right. So the dermatome that is normal is the one that you have to choose to go above that. So you got C3 on the right. What have you got on the left?
C4 on the left.
Are you sure?
Yes.
So if C4 is normal, then you have to assume that myotome is normal. That's a 5/5. So what would be your myotomal level on the left?
C5 then.
Okay. So your neurological level of injury then would be,
C3.
all right? And are you going to call this a complete or an incomplete injury?
It is complete.
All right. So your Asia impairment scale is going to be,
Asia A.
all righty. And you have a zone of partial preservation
Yes.
for
So
sensory.
sensory right C5, sensory left C5, motor right C6, motor left C6.
All righty. So let's see how you did. Looks like you did a good job going all the way through there. It's a little trickier being the second person because then I'm throwing some tricks at you. So you did a good job. So ultimately you would present this person to me as an individual with C3 Asia impairment scale A tetraplegia. Do you agree with that?
I concur.
You concur. All right. All righty. I need another volunteer, and I know I'm running out of time, so I'm gonna do just two more. My next volunteer will be Dr. Acosta. How about that?
I'm here, Dr. Gator.
Way to volunteer. So our next case, tell me what you're going to list out as the sensory level on the right.
So on the right, the sensory level is T12.
Okay. And how about on the left?
On the left, it is also T12.
T12. What's your motor level going to be?
Let's see. I'm going to start off with the left side because I feel more confident about my answer. On the left, it is T12.
Okay.
On the right, it is T12. Yeah. Yeah,
All
so
right.
it's both sides it's T12 on both sides, the motor.
So what would you call the neurological level of injury?
I would say T12.
All right. And would you call this complete or incomplete injury?
It is an incomplete injury
And why is that?
because they have deep anal pressure present.
All righty. So what would you assign as Asia impairment scale?
Huh, okay. So it is not an A. It's either B, C, D, or E. So let's see. They do have some preserved motor below the level of injury. So
More than 3 levels below the level of the injury?
3. Yes, they do.
Okay.
On the left.
Yeah.
However, it is not more than gravity, so it is not an Asia D. I'm going to say an Asia C.
Okay. Asia impairment scale C, the zone of partial preservation for sensory.
For sensory, on the left side, it is at L4.
Well, you don't actually report it.
Okay.
Because you've got deep anal pressure. Okay.
Okay,
So no
okay.
sensory on either side. And then motor
Motor
on the
on
right.
the left is
Okay.
1 at L4.
Okay. So, and on the right, it's,
There is no zone of partial preservation.
okay. So you could go ahead and just list T12 there or put a dash, either way.
Okay.
All righty. Good job. I'm just about out of time, but let me do one more case. And I don't know, maybe I should go with Dr. Mzambwe.
All right.
Are you there, Maja?
I am.
I am. That sounds fairly authoritative. So, Dr. Mzambwe,
Yes, sir.
tell me what you would list as a sensory level for case 4.
So the sensory level for case 4 on the right, I would put the sensory level at T12. And on the left, I would put the sensory level at T12 as well.
How about a motor level?
Motor level for on the right is going to be T12. And then motor level on the left, I see T12 as well.
Okay, this is sounding fairly familiar so far. What about the neurological level of injury?
The neurological level of injury is going to be T12 as well.
Alrighty. Complete or incomplete?
So deep anal pressure is not present. So it's going to be a complete T12 injury.
Asia impairment scale.
Asia impairment scale A.
Alrighty. And so what would we list as sensory and motor zone of partial preservation?
For the sensory on the right, there is no zone of partial preservation. And for motor, there's no zone of partial preservation. On the left, there is a zone of partial preservation for light touch at L1. And at the L2, there is a zone of partial preservation for the L2 myotome.
Okay, so you got the
Okay,
L2
so
myotome.
light touch is all the way down to L4, excuse me.
Alrighty. Excellent. All right. I think I've run out of time. I want to jump ahead and just finish these out, boom, boom, or try to. We don't have enough time to get all of these cases in. So let me just finish today with this. Optional testing. You can also report out joint position and or vibration as we're going through this to give us a little bit more information. We can talk about deep pressure points as being present or absent at the wrist, thumbnail, fingernail, medial malleolus toenail, or the 5th toenail. And then we have these optional motor testing that we can also determine. And I think I'm going to have to spend some time in the future discussing some of these as we go through. But Vivor's sign is helpful for us. That's when the person is laying down and we ask them to lift their head and shoulders up off the bed. If when they try to do that, their umbilicus moves up more than a centimeter, we say they have a positive Vivor sign. And it tells us that they have upper abdominal but not lower abdominal muscles working. It gives us some idea of how their stability is going to be in their chair and what kind of a cough they might have as we go through there. So I'm sorry we ran through a little bit long today. We can discuss cases at another time perhaps, probably as you rotate through with me. Are there questions, thoughts, or concerns though before I leave for today?
So I had a question about the updated guidelines.
Yes.
Were they primarily focused on describing the zone of preservation, or were there other changes that were clinically applicable?
Yeah, that's an excellent question. So part of why they've updated the guidelines is to see if we can collect information that helps us prognosticate better. So zone of partial preservation, yes, was a part of that. We're also trying to make a determination if we collect the data, will we know more about prognosis with light touch or with pinprick or motor function that hasn't always been captured the way that the INSCI exam has been demonstrated previously. So that's the major reason for the updated guidelines. In fact, Drs. Shea and Kirschblum just put out a new article in North American Clinics, the Clinics of North America, PM&R Clinics of North America on prognosis. And I'll actually be going through a little bit of this during my next lecture on prognosis for spinal cord injury. So hopefully you'll get a little bit more information in that next lecture as well.
Thank you so much.
Thank you all for your time and attention. I hope you have a great day.